All right, so we'll get started with an introduction. Today, our speaker is Dr. Alex Koo. He's a PGY1 resident at the University of Utah Health in the ambulatory care track. He received his PharmD from Roseman University in Henderson, Nevada, and his MS in pharmacology from Yale University, his BS in pharmacology and toxicology from the University of Wisconsin-Madison. Dr. Koo's current interests include academia and all things ambulatory care. And a quick update, he's taken a PGY2 with us in drug information, and we're very excited at the University of Utah. He's excited to present his CE today about the current state of COPD guidelines. I'm passing it to you, Dr. Koo.
All right. Thank you so much for that, Dr. Mullen. Again, thank you for that introduction. Today, I will be presenting my CE entitled From Group A to E, a COPD guideline update. To start off with disclosures, no relevant financial conflicts of interest for myself or for my mentor, Dr. Dave Young. And in terms of off-label uses of medications, I will be talking about an off-label use of azithromycin during this presentation. The learning objectives are as follows. For pharmacists, 1, to recommend at least one appropriate COPD treatment regimen based on GOLD group classification, to evaluate at least one patient-specific factor to determine appropriate inhaler device options, and to be able to propose at least one alternative COPD medication within the same therapeutic class. For technicians, the learning objectives are as follows. 1, to differentiate between metered dose inhalers and dry powder inhalers, to identify if an inhaler contains a LAMA, LABA, or an ICS, and to be able to list the 3 different GOLD group classifications. For the agenda of today's presentation, I'll be starting with some background and then going and talking about the different bronchodilator options that we have available, talking about additional treatment considerations, so kind of beyond what we expect from group A to E, as well as a longitudinal patient case that'll kind of track throughout today's presentation. So starting with that background, really, what is COPD? Well, it's short for chronic obstructive pulmonary disorder, and it boils down to just chronic inflammation of the lungs resulting in obstruction. So that inflammation causes restructuring, and now it's much harder for the patient to breathe, have that gas exchange. This is often characterized by dyspnea, wheezing, chest tightness, as well as cough, and this may present with or without sputum. There are a variety of different risk factors for COPD, both genetic and environmental. Amongst the genetic risk factors, the most well characterized is the SERPINA1 mutation, which leads to an alpha-1 antitrypsin deficiency. And this deficiency is important because alpha-1 antitrypsin is involved in an anti-inflammatory effect within the lungs. So that's deficient, then inflammation is much easier to occur, contributing to COPD. In terms of environmental risk factors, tobacco smoke, which I believe is probably the first thing that will come to mind if you would think of risk factors for COPD. Biomass exposure, so things like wood-burning stoves or burnt biomass. Occupational exposures based on job, as well as air pollution. So for me, I think inversion. It's that time of year. And I did want to note that at this point, in terms of cannabis smoking, there is an unclear connection. And the current thought is any risk that might exist can be contributed more to the smoking aspect and not necessarily the cannabis itself. So in terms of the pathophysiology of COPD, just really boiling it down, like I mentioned, that increase in inflammation will lead to structural changes, things like remodeling of small airways, parenchymal destruction, as well as alterations to the vasculature of the lungs. These structural changes then lead to airflow limitation, aberrations in gas exchange, which then leads to more inflammation, which leads to more structural changes, kind of in this negative or a negative loop that we see here in this cycle. In terms of the epidemiology of COPD, there are about 2.5 million people with COPD in the United States. Specifically within Utah, we have 96,400. people living with COPD. It is the fourth highest cause of death in the US at 105.6 deaths per 100,000 people. So we can see here in this image from the CDC that Utah definitely falls in the lower side of that range that we see amongst the US. And Utah specifically has 86 deaths per 100,000. So to diagnose COPD, this is diagnosed via spirometry. And when looking at those spirometry results, we are looking specifically at the forced expiratory volume in 1 second, or FEV1 value, and the forced vital capacity, or FVC number. And we do a comparison of them taking FEV1 over FVC. And if that number comes back as less than 0.7 or less than 70%, then that would confirm a diagnosis of COPD. Now, here's an example of what we might see as a spirometry report in EPIC. A lot of information, a lot of numbers, and do all these numbers really matter when thinking about just COPD and that diagnosis? Not particularly. It's really these three numbers up here that I wanted to focus in on of the FVC, FEV1, and then again, that comparison of FEV1 over FVC, which we see in this case for this report is 70%, which would not count as a COPD diagnosis because it's not less than 70%. Now, in addition to the diagnosis or after diagnosis, there are different GOLD grades, which characterize the severity of airflow obstruction, ranging from mild to very severe, increasing from GOLD 1 to 2, 3 to 4. And this is looking specifically at FEV1 of the patient, and then comparing that to what their predicted value would be if they weren't having that obstruction. So mild would be 80% of predicted, moderate is 50 to 79% of predicted, severe is between 30 to 49% predicted, and very severe is less than 30% of what they would predict. Additionally, there is GOLD group classifications, and this really helps characterize the patient's symptoms, exacerbations, and determine proper treatment for them. What I have on the screen currently is former GOLD group classifications that are no longer the most up to date, but is probably what a lot of people are familiar with. This is definitely what I learned when I was in school, where we have group A, B, C, and D with a variety of different treatment options. So any bronchodilator for group A, a long-acting bronchodilator in group B, LAMA monotherapy in group C, and then any of these three different options that we can see in group D. Now, as of last year in 2023, there was a pretty big overhaul to the GOLD group classifications, where now there is group A, B, and E. And in addition to that, the various treatment options have also been simplified. So now group A, very similar, any bronchodilator, however, an asterisk that a long-acting bronchodilator is preferred. Group B is combination LABA-LAMA treatment, and group E is combination LABA-LAMA treatment with an asterisk of adding an inhaled corticosteroid based on eosinophil count. Similarly, where they place in the groups has not changed, where along the y-axis, it's based on exacerbations. So if they've been hospitalized for an exacerbation, or if they've had 2 or more moderate exacerbations, so needing a systemic oral corticosteroid or antibiotics, that automatically will put them in group E as it spans the entire x-axis. And then along the x-axis, we look at the severity of the patient's symptoms. So we look at CAT score as well as MMRC, which I'll describe a little bit more in the next couple slides. But overall, really, it's been simplified from 5, 6 different treatment options in the previous GOLD group classifications to really 2, maybe 3, if the patient needs to be on an ICS as well in the current GOLD group classifications. So I mentioned CAT score, which is the COPD assessment test. And this is a questionnaire of 8 items that are scored from 0 to 5. 0 meaning either the symptom never happens or overall there's no big impact on the patient's life. with 5 being that the symptom is always present or there is some negative impact on the patient's life. So the items that they look at are cough, phlegm, chest tightness, breathlessness, their ability to do day-to-day activities, their confidence in being able to do those day-to-day activities or being able to just function, their sleep quality, as well as their energy levels. And another way that their symptoms are scored is through the Modified Medical Research Council Dyspnea Scale, or MMRC. This is a scale of 0 to 4 that assesses their dyspnea severity. So a 0 being that they only experience that dyspnea with strenuous exercise, 1 being when they're hurrying, maybe they need to catch a bus that they're running late for, or walking up a slight hill. 2 being that they note that they walk slower than those their age, or they do have to stop for breath even when they're going at their own pace. A 3 noting that they stop for breath after walking not too long of a distance, about 100 yards, or after a few minutes. And a 4 being the highest level of dyspnea where it prevents them from leaving the house, or they even experience breathlessness when doing something as simple as getting dressed. Now, I mentioned that patient case that would be kind of following us through today's presentation, and we'll get started on that now. So I have here patient TL, who is a 57-year-old woman newly diagnosed with COPD. Her provider is consulting with clinical pharmacy to assist with her medication management. Some relevant information about patient TL is that she has a history of 1 moderate exacerbation, and this is what led to her diagnosis of COPD, a CAT score of 15, an eosinophil count of 86, and noting that all her vaccines are up to date. So this brings me to our first question of the day, which is for technicians. Which of the following are the current gold group classifications? So we have, I'll go slow because it's a little bit confusing. So we have A, which are groups A, B, C, and D. Option B, which is groups A, B, and C. Option C, which is groups A, B, and D. Or option D, which is groups A, B, and E. So I'll give some time to get that response going. And let me pull up the poll everywhere. You just switch back. All right, so it looks like it's trickling down. So looking at the responses, pretty solidly, a lot of people are leaning towards option D, which is correct in this case. So option A is incorrect, as A, B, C, and D are the previous gold groups, and this was again replaced in 2023. Option B is incorrect because there's no longer a group C. Option C is incorrect because there's no longer a group D, and option D is correct as the current groups are A, B, and E. So now going back to my presentation, here's the first question for pharmacists. So based on TL's exacerbation history, which is again 1 moderate exacerbation and CAT score of 15, which of the following choices appropriately classifies her gold group and suggests an appropriate pharmacotherapy option? So we have A, group A, and patient should be given Atrovent, which is a SALMA. We have option B, which the patient would be in group B and should be given Trilogy Ellipta, which is a LABA-LAMA ICS combination. We have option C, which the patient should be in group B and given Stiolto Respimat, which is a LABA-LAMA combination. Or we have option D, where the patient should be classified as group E and given Briolipta, which is a LABA ICS. So let me get poll everywhere pulled up and switch to the next question. Again, I'll give about 20, 30 seconds. All right, so looks like the last couple responses are coming in. So looking at the responses right now, strong lean towards C, which in this case would be the correct answer. So option A is incorrect because patient TL would not be classified into group A because looking at CAT score, so it's less than 10, greater than or equal to 10. At 15, she's solidly on the right side of that chart. And additionally, she should be receiving a LABA-LAMA combination, and Atrovent being a SAMA is not appropriate treatment for a patient in group B. Option B is incorrect because while the classification is accurate at group B, Choljolipta is not an appropriate treatment for group B as there's that ICS included. Again, like I mentioned, C is correct because the patient falls into group B. And then Cialto is a LABA-LAMA combination, which would be appropriate for that group. And D is incorrect because the patient would not be classified as group E because she's only had one moderate exacerbation, not two, nor has she been hospitalized for that exacerbation. And additionally, Briolipta is not an appropriate group B treatment, again, because there's that ICS there, and it would need additional LAMA. All right. So now I'm going to talk about the different bronchodilator options that we have available to us to treat COPD. Starting first with the short-acting bronchodilators. So this falls into two different groups. So we have short-acting beta agonists or SABAs and short-acting short-acting muscarinic antagonists or SAMAs. So for the SABAs, we have albuterol and levoalbuterol. For albuterol, there's a variety of different brand names. We'll most commonly see are ProAir in both the Respaclick or Digihaler forms, Proventil HFA or Ventolin HFA. And for levoalbuterol, we do have Xopenex HFA. In terms of SAMAs, we have one option, which is ipratropium, which is available as Atrovent HFA. And we do have a combination product of both SAMA and SABA together, which is a combination of ipratropium and albuterol, which is Combivent, which is available as a Respimat. I do want to note as well that these are also available as nebulizing solutions. Now, going into the long-acting beta agonists, we have four options that are available to treat COPD. We have salmeterol, which is available as Cerebin Discus. We have olodaterol, which is available as Striverdi Respimat, formoterol, which is Perforomist, and arformoterol, which is Brovana. Formoterol and arformoterol is noted on the left. I put neb because that means they're only available as a nebulizer solution. Meanwhile, salmeterol is available as a DPI or a dry powder inhaler, and olodaterol is available as SMI or soft mist inhaler. And these classifications or descriptions will be available for the rest of the inhalers I go through. So now we have the long-acting muscarinic antagonists or the LAMAs. Again, four options that are available on the market to treat COPD. We have umilcadinium or Incruse, Ellipta, which is a DPI, tiotropium, which is available both as Spiriva HandiHaler and Spiriva Respimat, the HandiHaler being a DPI with the Respimat being an SMI. We have aclidinium or Tudorza Pressair, which is a dry powder inhaler formulation. And we have revefenacin or Yupelri, which is available as a nebulizer solution. Now we're going to start to branch into our combination inhalers, starting off with our LABA ICS combinations, which you may note is no longer included in that gold group classification treatment list, while it was previously in the 2023 or prior to the 2023 classifications. And I'm just noting it here because these are still approved for the treatment of COPD. So we have fluticasone salmeterol, which is available as Advair Discus or as Blixella Inhub, both of these being dry powder inhaler formulations. And I did want to note that Advair HFA, while available, is not approved for COPD. We also have fluticasone vilanterol or Brio ellipta, which is also available as a dry powder inhaler. And we have budesonide formoterol or Symbicort, which is an MDI or a metered dose inhaler. Going further into these combination inhalers, we now have our LAMA-LABA combination. So at this point in the treatment guidelines, probably the most common things you will see used to treat COPD. And there are 4 options that are available. We have umecadinium vilanterol, which brand name is Anorolipta, which is a DPI. We have glycopyrrolate and formoterol, which is Bevespi Aerosphere, and Aerosphere being an MDI. We have aclidinium formoterol, or the Duoclear Press Air, which is a DPI. And we have tiotropium olodaterol, which is steel to respimat, which is an SMI or softness inhaler, and was, again, the correct answer to the previous question. And getting into our last batch of combination inhalers, we have the triple inhalers, which have a LAMA, LABA, and an ICS. So we have 2 options, which we have Trilogy ellipta, which is fluticasone, umeclidinium, and vilanterol, and is a DPI. And we have Breztri Aerosphere, which is budesonide, glycopyrrolate, and formoterol, which is a metered dose inhaler. Now, that was a lot of information all at once about a bunch of different inhalers. And honestly, I personally would even have to go cross-check, make sure I'm looking at things correctly and remembering what those ingredients are. So it's really easy in the sea of inhalers to lose track of what's what and what's going on. And what I've found is a good rule of thumb is that each manufacturer has their own inhaler type that they manufacture. And amongst that specific inhaler type, the medications are often mixed and matched. So, for example, I pulled all the ellipta inhalers that we have available in this kind of Venn diagram here, where looking at the 3 main ingredients, we have fluticasone, which is available as our Arnuity ellipta, umeclidinium, which is available as Incrus ellipta, and vilanterol, which doesn't have a single inhaler product. And noting that Arnuity wasn't mentioned previously because it doesn't have a COPD approval, but there is that product available. And then if you look here, if we were to combine fluticasone and vilanterol, we get Brio. If we were to combine vilanterol and umeclidinium, we get Anoro. And if we combine all 3, we get Trelegy. So how I like to approach it is really trying to memorize one big one like Trelegy, knowing what 3 is in there. And then I'll know if I'm working with an ellipta inhaler, it's going to have some combination or single ingredient of either fluticasone, umeclidinium, or vilanterol. And this may come in handy. For example, maybe Trelegy isn't on formulary. So what's a possible option? We could go maybe Anoro to hit the vilanterol and umeclidinium, and then add on Arnuity to get that fluticasone aspect to be equivalent to Trelegy. Or on the flip side, we could also go with Brio, which has fluticasone and vilanterol, and then add on umeclidinium as Incrus to add up and get the umeclidinium aspect as well. So just kind of keeping in mind, if you think about the inhaler type and what the name is, you can often kind of infer the ingredients of other ones in that same inhaler type. Another factor to consider when thinking about what to prescribe and what to get for patients is once daily versus twice daily dosing. So we have bronchodilators that are able to be dosed once a day. So amongst our LAMAs, we have umeclidinium, revefenacin, and tiotropium. And amongst our LABAs, we have olodaterol and vilanterol. So a mnemonic I've used to remember this is apt to residents, but undergoing residency training, obviously vigorous. So umeclidinium, revefenacin, tiotropium, olodaterol, vilanterol. On the flip side, for twice daily dosing, you could also just think, what are the other ones? But as well, those are the LAMAs being aclidinium and glycopyrrolate, and the LABAs being salmeterol, formoterol, and arformoterol. And the mnemonic I came up with this one is, after graduation, search for a job. So really just kind of thinking, what's the overall experience of a resident? Kind of turn that into my mnemonic. And that this is just a way to remember which inhalers are once daily versus twice daily. as maybe for the patient, they have some maybe adherence hurdles that a once daily would be easier, or maybe they don't care, or also maybe their insurance would prefer one inhaler over the other. They would still prefer once daily, so kind of thinking what other once daily options exist for those patients. And earlier as well, I was talking about those different inhaler types. So we have MDIs or metered dose inhalers, which there are 4 different ways you would see that expressed in the medication name as an HFA, which stands for the propellant hydrofluoroalkane of that inhaler to give that spray. We have Aerospheres, Redihalers, which I put an asterisk because there is no Redihaler product available for COPD, but it's still an MDI that we have. Or if the type of inhaler is not specified within the product name, often that you can assume that it's the MDI, an example being Symbicort. For the dry powder inhalers, there's even more of what we can see available. We have the Respiclick and Digihaler, which I've lumped together because the Digihaler is just a Respiclick with Bluetooth technology. We also have Ellipta, Discus, InHub, PressAir, HandyHaler, and then Twisted-Haler, FlexHaler, and Redihalers, again, have an asterisk because there are not a COPD product available. And finally, we have soft mist inhalers, where the only one available is a Respimat. So with these different inhalers, there are different considerations, different things to think about when maybe preferring one over the other and seeing what might work best for a patient, as well as counseling points to touch on with those patients. So for MDIs, here are some different considerations there. So something, I don't have pictures in my slides, unfortunately, but I do have examples with me. My picture is probably tiny, but they'll be here, kind of me demonstrating and talking about what I'm actually mentioning. But so MDIs, I'd say, are probably the quintessential inhaler. Often what comes to mind for patients when you mention an inhaler. So it's kind of this L shape, you shake it, there's a spray. Something to consider is that these often require significant coordination for proper use. Again, getting that spray and inhalation at the same time. And that timing really is key for proper administration and deposition to occur for the medication in the lungs. Spacers can help with this coordination. Oftentimes we think spacers are best for those who are very young or children, as well as the elderly, but honestly, I think it's worthwhile to offer to all patients, even those who might be just young adult ages, because it can possibly make their life easier, it increase adherence and just increase effectiveness of therapy. And something to note that it can be difficult to use the device if the patient's hands lack fine motor function or even strength, like being able to get the cap off, replace it, clean out the inhaler, as well as being able to actually press down and get the spray to happen. I've had patients where their hands just could not get the spray to go. Thinking about key counseling points, one of the biggest missteps I see for patients is that they are not inhaling correctly. So oftentimes they go a quick deep breath, which for an MDI is not what we want. We want the patients to do a slow and deep inhale, because the way I always describe it is the inhaler is doing the work for them. It's spraying it. They just have to breathe in. Something important is to always replace the mouthpiece cap, one, to prevent wasted doses, to not have it accidentally spray if it's in a bag or something, or to get clogged because particulates, dust, whatever, coins can even get into the mouthpiece. The plastic housing of the inhaler should be cleaned weekly, just taking out the medication canister, running hot water through both ends for 5-10 seconds, and then letting it dry completely before putting the medication back in. So often just leaving it overnight to dry. And noting as well that the inhaler may need to be reprimed if not used frequently. This timing is very product specific, so depending on what the patient's taking, you would have to check the package insert. For example, Ventolin can go 14 days before needing to be reprimed, versus Symbicort needs repriming after 7 days. Next, looking at the dry powder inhalers and those considerations, something that really sets it apart from MDIs is that it does not requires much coordination, where since it's the patient's breath inhalation that's propelling the medication into their lungs, the inhalation is the actuation. And comparatively to MDIs, it's often easier to utilize dry powder inhalers for inpatients that, again, lack that fine motor function. So for an elliptic here that I have, all it takes is opening it and it's set up. And then they have to breathe in. There's a lot less coordination. It's a big piece that they have to move that doesn't require like squeezing or really utilizing your fingertips at all. Though they cannot be used with spacer devices, but again, this is less of an issue because inhalation is the actuation. In terms of key counseling points for dry powder inhalers, so unlike the MDIs, patients do need to do that quick, deep inhale for dry powder inhalers because there is nothing to spray it out. It's that inhalation that pulls it into the lungs. As a dry powder inhaler, it must be kept dry. So in terms of cleaning for these, it's often using a clean, dry cloth to just wipe off like the mouthpiece, areas that might get a little bit gunky, just to clear those off, but not using anything damp or wet. In general, you definitely keep the inhaler upright just to prevent a wasted dose, because once it's open, clicked into place, the powder's there sitting. If you were to turn it upside down, the patient would lose their dose. Similarly, another way to waste doses is if they were to open, close it multiple times, then each time it would be actuating a new dose and wasting the previous one. So a good counseling point for patients in those cases, if maybe they have children or grandchildren around, to keep it definitely out of their reach, because they get on their hands on it, treat it like a toy, they may run through their entire inhaler in a single day on accident. And lastly, we have the soft mist inhaler, or the Respimat, which again is the only option available for this group. This does spray. It is a slower spray, which makes it easier to coordinate with inhalation, so not nearly as quick as an MDI, but the device can be hard to use, again, for patients whose hands lack strength or lack that fine motor function. So the way you use a Respimat is called top or twist or turn, open, push. And oftentimes it can be hard for the patient to turn the inhaler. There's a lot of resistance, and sometimes considering whether or not that is doable for the patient, or if you have a demo device, having them try and see if they're able to do it. Respimats cannot be used with a spacer device, so keeping that in mind, even though there is a spray, they're not approved for use of spacer devices. And the device does require setup after being picked up from the pharmacy and getting everything put together. So oftentimes, it's not a good chance to counsel the patient, show them how to do it the first time, because I've definitely had patients come in after the fact with the Respimat being like, I don't know what to do. So something to consider there. Some key counseling points for the soft mist inhaler is, since there is a spray, the inhaler is doing the work. This is another case where the patient needs to inhale slowly and deeply. The mouthpiece does need to be cleaned on a weekly basis to prevent clogging. So that includes this plastic part here, but as well as the inside, there is a metal piece where the medication gets sprayed through. That should also have to be cleaned, because if that's clogged, no medication is going to be coming out. The inhaler needs to be reprimed once after 3 days of no use. So just going through the motions, making sure it sprays, and then repriming it until a spray is seen if it's not used for 3 weeks or longer. So that first 1 or 2 primes, there may not be a spray. So going until you see that spray happening. So a lot of information to put together. So to really hopefully have that stick, we'll get into the next part of the patient case. So we have patient TL. After meeting with us and discussing the various inhaler options, we've learned the following. TL has osteoarthritis of the hands, so it does make it hard to grip things for the patient. Due to her busy schedule, she would prefer a once daily medication. And patient TL, aside from those factors, really doesn't have a preference between the different inhaler types. She is okay with whatever we want to go with. So for our first question for pharmacists, we have, based on TL's patient-specific factors, so that once daily regimen, as well as osteoarthritis of the hands, and the gold group classification, which pulling it back was group B, which of the following treatment options would be the most appropriate? So you have A, Duoclair Press Air, which is aclidinium plus formoterol. Option B, which is Bevespi Aerosphere, which is glycopyrrolate plus formoterol. We have C, Honora ellipta, which is umlicadinium plus vilanterol. And we have D, Stiolto-Respimat, which is tiotropium plus olodaterol. So let me switch to poll everywhere and give about half a minute. All right, I think the last couple answers are trickling in. Let's see what everyone's looking at. So I'm seeing some options between C and D, with C definitely outclassing D, and I see changes happening right now. But the correct answer for this question is C. So option A, while a DPI being appropriate for the patient's osteoarthritis, the medications are a part of a twice daily regimen. So aclidinium and formoterol being twice daily medications, which do not fit in with that preference of the patient. Option B is incorrect because an Aerosphere is a type of MDI, which would be inappropriate for the patient's osteoarthritis. And the medications glycopyrrolate and formoterol are also twice daily medications. So doesn't hit either of those patient-specific factors. Option C is correct because Honora ellipta, so ellipta is a DPI, easy on the hands, and umlicadinium and vilanterol are once daily regimens. So it fits both of her aspects. And then option D for Stiolto-Respimat is incorrect because the Respimat being a soft mist inhaler can be hard on the hands for her to use, so it doesn't necessarily fit into that patient-specific factor. But the medications are a once daily regimen, so that part is correct, but overall, because of the inhaler, it's overall incorrect. So going in back to the presentation and going to the next question for technicians. So due to TL's osteoarthritis of the hand, she would benefit from using a DPI. Which of the following devices would be an appropriate choice? We have A, Respimat, B, Aerosphere, C, Press Air, or D, an HFA inhaler. So I'll switch back over to poll everywhere, get that pulled up, and give about half a minute. All right, so let those last couple answers trickle in. Let's see what it's looking like here. So suddenly everything's changing as people saw the answers, but the correct answer is actually C. Because again, we're looking for specifically a dry powder inhaler. So the Respimat group option A is a soft mist inhaler, so that's incorrect. Option B, an Aerosphere is an MDI, which is incorrect. Press Air is a dry powder inhaler, which would fit what the question's asking. And option D, an HFA inhaler, is incorrect because, again, it is an MDI or meter dose inhaler. All right. So now, kind of thinking beyond Group E, what are some other treatment considerations we need to think about for our patients? So, of course, patients might experience exacerbations. And when we think about those symptoms, it's kind of this trio of increased dyspnea, increased sputum production, and sputum purulence. So, when thinking about exacerbation, how do we want to treat our patients? Because this falls kind of outside of that GOLD classification, but it's something we should still know and consider. So first, patients should be given some sort of quick acting or fast acting, short acting bronchodilator. So a SABA and or a SAMA. So we're also kind of thinking about what the patient's been on and going from there. And this can be either an inhaler or a nebulizer treatment. So if they were just on albuterol HFA out prior to their exacerbation, maybe getting them on COMBIVENT to kind of give them that extra help to get them through their exacerbation. They should also be given systemic corticosteroids, some equivalent of 40 milligrams per day of prednisone for 5 days is the commonly accepted duration of treatment for the corticosteroids, and antibiotics as well. And whether or not to use antibiotics is based on, again, the symptoms that the patient presents with. So they need to have sputum purulence, and then at least one other of those three symptoms of exacerbation. So either increased sputum volume or increased dyspnea. So if they have sputum purulence and increased volume of sputum, give them an antibiotic. If they have purulence and dyspnea, give them an antibiotic. But if they only have volume and dyspnea, then they wouldn't necessarily qualify for an antibiotic because that sputum purulence is not present. And for antibiotics, again, a 5-day treatment duration is really as much as the patient needs, so they will only really be on additional medications for 5 days. They did note in the GOLD guidelines that methylxanthines are recommended against due to side effects. So that's theophylline, aminophylline, with their side effects like tremor, seizure, tachycardia, GERD, GI ulceration. So the risks just really outweigh the benefits of those medications in these patients. But let's say your patients had an exacerbation, you treat them, what next? So in terms of escalating treatment, if you were to look at what it was prior to the group overhaul, there's a little bit more maze-like, more options, but since there are fewer treatment options, escalating is also a lot easier. So for dyspnea, if they were starting in group A with just a bronchodilator, we would move up to group B with the LAMA-LAMA. And then at that point, if that's not helping the patient with their dyspnea, then we would need to consider other factors. So environmental factors, like maybe are they reacting to pet dander? Is there dust, mold, allergies, inversion going on that could be leading to the patient's symptoms? Or even infection. Maybe the patient has a respiratory infection that's leading to this dyspnea that has not been identified. In terms of exacerbations and treatment escalation, so if they start in group A with a bronchodilator, there are two options to move to. So, and this is based off eosinophil count. So if they have an exacerbation and their eosinophils are less than 300, they would move up to group B, which is LAMA and LABA. If they have an eosinophil count of 300 or more, then at that point we would consider, okay, let's add an ICS. So it'd be a LAMA, LABA, ICS. So essentially group E, if you were thinking about it that way. Then if the patient has this LABA-LAMA and they're still having an exacerbation, we would check their eosinophils again. There's a slightly lower threshold this time of is it at least 100? In that case, then we add on ICS. And there's no real de-escalation in this algorithm, but if the patient is starting to experience side effects like maybe constant thrush, constant side effects from the ICS part of the medications, then we can actually take that off and bring them back to just LABA-LAMA therapy. And then finally, let's say they're on LABA-LAMA therapy and their eosinophils are not at least 100, or they're on triple therapy and they're still having exacerbations, then future options are either roflumilast or azithromycin. So think about treatment-wise beyond Group E, we have roflumilast, brand name Daliresp. One thing about patients to give this medication to, really looking at those with an FEV1 of less than 50% predicted. And if you think back to the GOLD grades, this would be GOLD grade 3 or GOLD grade 4. Those who have chronic bronchitis or have been hospitalized for an exacerbation in the last year. So really leaning towards giving roflumilast to these patients. Another option would be daily azithromycin. This is that off-label indication I mentioned at the beginning of the presentation. Generally leaning towards former smokers for this medication, but also noting that while daily and chronic, there's not sufficient evidence really to support use beyond 1 year in preventing further exacerbation. I also do want to note that while I do say azithromycin daily, it is 250 milligrams daily. There's also an option of doing 500 milligrams 3 times a week. So, but still chronic use in general. And then lastly, just want to touch on vaccinations. I feel like it's very important and really always room and a spot where pharmacists can make that impact and identify gaps and really be able to improve patient care. The patients should always receive if they have COPD, should receive seasonal influenza vaccine. They should receive an updated COVID-19 vaccine, pneumococcal vaccine, which if they have no history of it, Prevnar 20 is always a good go-to because it's a one and done. If they're 60 or older, they should receive the RSV vaccine and make sure that they're up to date on their Tdap and zoster/Shingrix vaccines there. And then I did want to note for the pneumococcal vaccine, things change all the time, recommendation-wise. I think it's changed like 3 or 4 times since I was a student and learned it. I found that there's an app from the CDC called PneumoRx that's very useful. It's just a questionnaire. You fill in details about your patient, and it'll give you a recommendation of what vaccine they should get, or if they're up to date, caught up, and don't need a vaccine at all. All right, so getting back into the patient case to wrap it up with the last couple questions. So patient TL went to the pharmacy to pick up her Noro, Ellipta, and was told it's not on her insurance's formulary. And not listed here, probably too expensive for her to pick up. So she contacted the clinical pharmacy, and informed us that while she has osteoarthritis, she did ask the pharmacy about the Respimat. They had a demo. She tried it. She was able to use it perfectly fine. So it's really only the HFA inhalers or MDIs that she cannot use with her hands. And now that she knows there's some red tape in the way, that while she would prefer a once daily medication, she is okay with going a twice daily medication. So for the final pharmacist question, I have, which of the following options are an appropriate substitution for Noro Ellipta and addresses TL's patient-specific considerations? So now really the only consideration is inability to use an HFA inhaler/MDI inhaler. We have option A, Duoclair Press Air, which is aclidinium formoterol. B, Bevespi Aerosphere, which is glycopyrrolate formoterol. C, Breo Ellipta, which is fluticasone melantrol. And D, Stiolto Respimat, which is tiotropium inolaterol. And this is a select all that apply question. So there will be multiple answer choices or multiple correct answers. And let's let it go. All right. So let those last couple answers trickle in. See where things are looking at right now. Pretty even spread. So what are the correct answers? So its answers A and D. So A is correct because the press air is a DPI, which is perfectly easy for the patient to use. And the medications are a twice daily regimen, which now the patient, while preferring once daily, is fine with doing. So it would work for her. So that's a correct answer. B is incorrect because the Aerosphere is an MDI, which the patient mentioned she can't really use still. Uh, and the medications regimen, timing, frequency doesn't really matter for her anymore. So it's really the inhaler that rules out B as being incorrect. C is incorrect because while Briolipta is a DPI, the medications of fluticasone and vilanterol are not an appropriate substitution for Onoro. So Onoro is a LABA-LAMA, while Brio is an ICS LABA. So not appropriate as a replacement or substitution. And option C is correct because now we know patient TL can use a Respimat, which makes it okay for it to go with that. And tiotropium olodaterol is a once daily regimen, so it would work with the patient's preferences. And now going to the last question of the presentation for technicians. Combivent, which is ipratropium albuterol, contains which types of medications? This also is a select all that apply question. We have A, short-acting muscarinic antagonists, or SAMA. B, long-acting muscarinic antagonist, or LAMA. C, short-acting beta agonist, SABA. Or D, long-acting beta agonist, or LABA. All right, I'll let that go. All right, gonna let those last couple answers trickle in. Looking like everyone's leaning very strongly towards A and C, which is correct. So I think all the way back to that first Venn diagram, Retroprium is a SAMA, albuterol is a SABA. So those are the two ingredients that are present in Combivent. So A is correct because, like I said, ipratropium is a SAMA. B is incorrect because there is no LABA present. C is correct because albuterol is a SABA, and D is incorrect because there is no LABA present. All right, so at that point, that does wrap up my presentation. So I do want to thank everybody for attending. And again, a special thanks to my mentor, Dr. Dave Young, for his assistance in the creation of this presentation. And at this point, I think we do have a couple minutes left for questions if there are any. Otherwise, again, thank you so much. And thank you for giving up your lunchtime for this.